everyone. In coming 20 minutes time, we will understand the side effect profile of EGFR TKIs and is there any difference in the side effect profile among the first, second, and third generation TKIs? So we know the stage 4 non-small cell lung cancer. If there is a contralateral lung nodule, or if there is a pleural or pericardial effusion or nodules which are present, then it is categorized as M1A. If the disease is confined to the thorax, and the moment it goes out to uh, outside the thorax, if there is a single extrathoracic metastasis, it becomes N1B. And if there are multiple extrathoracic metastases, it is M1. Uh, it becomes M1C. So all of these are considered stage 4 non-small cell lung cancer with any T, any N, and whether it is M1A, whether it is a contralateral lung nodule or a pleural nodule or an effusion, or whether it is a single extrathoracic mets, or whether there are multiple extrathoracic mets, all are M1A, B, and C, all are considered as stage 4 non-small cell lung cancer. Okay. Okay. So then coming on to the diagnostic workup, how to do a diagnostic workup. So it's very important that we have an adequate tissue for histological subtyping. Biopsy is a must, and then we need to understand whether it is an adenocarcinoma or a squamous cell carcinoma, or whether it is an adenosquamous. And you can see uh, then we have various ways, and NGS is one of the best ways where we can identify all the target mutations. And of course, there is always a role of rebiopsy at the time of progression to look into the mechanism of resistance to the first line treatment. And then uh, this is how we manage the target. This is how we have a management by which are driven by molecular tests. You can see one is histology driven, and then we have the mutation driven. You can see EGFR, ALK, ROS, BRAF, MET, PDL1. So these are all the target mutations which we have, and you can see the survival is nearly up to 3.5, 4 years. We are reaching survival if we can identify a target mutation, and if we can treat it, then definitely we can improve survival. So therefore, the moment we hear lung cancer, we need to have a histological classification, whether it is a non-small cell lung cancer or a small cell lung cancer. The moment it is non-small cell, which is more common, we need to histologically classify them into whether it is an adenocarcinoma or a squamous carcinoma. And the moment we have an adeno especially, we always have to look into the presence of driver mutations by various techniques. We use PCR, we use FISH, and NGS is a way where we can have multiple genes being analyzed simultaneously with a small amount of tissue, and which is more sensitive. And if we can identify that there is a single mutation behind the present lung cancer, if we can give treatment depending on the target, then we can improve the survival of a lung cancer patient for nearly more than 3 to 4 years. And that's the importance of doing a biopsy and finding out which driver mutation is responsible for this particular cancer. Okay, next slide. And then we have these are the target mutations which we have apart. So you can see that the whole chunk is around 30%, which is seen in brown, is mainly where we don't have any oncogenic driver mutation, and then we have another 25% having KRAS mutation. So the KRAS is a driver mutation, but unfortunately we don't have any drug targeting KRAS as of now. So therefore, KRAS is basically used to exclude the presence of other mutations. So you can see nearly 50% of patients will not be eligible for target therapy driven treatment. So we have the big chunk of rest 50%. You can see EGFR constituting the biggest percentage of the target driven part, and then we have the ALK, and then you can see the MET, and then we have ROS somewhere there, and then we have BRAF, RET, NTRK, PIK3CA, MEC, and so on. So this is how. And if you look into the EGFR, so we have Jeftinib, Erlotinib, first generation, and then we have second generation, Afatinib, Decomatinib, and then we have third generation, which is Osimertinib. These are the 5 drugs which are available to target against the EGFR mutation in lung cancer. Then you can see EGFR mutations which result in sensitivity and resistance to EGFR TKIs tend to cluster around exon 18, 19, 20, and 21. And these mutations are categorized as deletions, insertions, or point mutations, and are described as common or uncommon. You can see deletions refer to mutations caused by loss of sequence of DNA. Insertions are caused by additional sections of DNA being added, and point mutations occur when a single DNA base has been changed in sequence. So you can have a deletion. For example, we have exon 19 deletions, and then we have insertions, and then we have point mutations, like we see in exon 21. You can see the 3 mutation types are all found in structures around the ATP binding region of the EGFR, predominantly in the P loop and the alpha helix. So you can see the structure of the EGFR, the epidermal growth factor receptor, and then you can see the extracellular and the intracellular domain, and you can see the different components of it. And you can see in the tyrosine kinase domain or the ATP binding domain, you have the 4 exons 18, 19, 20, and 21. And you can see the type of mutation we see in exon 18. It's a point mutation G719X. They're not that sensitive to TKIs. Exon 18 is not that sensitive. And then comes exon 19, and the type of mutation we see is deletion. And this constitutes the highest percentage, nearly 46%. And then we have exon 20, which includes T790M and other exon 20 mutations. And then we have exon 21 mutation, which is around 37%. And then we have non L858R mutations like L861Q. So if you look into the ones that are shaded in yellow, so they are the ones which are exquisitely sensitive to TKI based treatment. You can see nearly 46 plus 37, uh, nearly more than 85% of patients will have a sensitive EGFR mutations, and they're sensitive to targeting by EGFR tyrosine kinase inhibitors, which target the tyrosine kinase ATP binding domain as well. And we have other uncommon EGFR mutations, the most common being there in the exon 20, then we have exon 18, and then we have exon 21. So what we can note here is the uncommon mutations, which are resistant mutations, are not basically seen in exon 19. We see it in exon 18, 20, and 21. Then we have, if you look into the EGFR positivity rate, there has always been a higher incidence of EGFR positivity in the Asian, especially in the Japanese population. You can see as high as 50% when compared to the Caucasian, where it's around 15 to 20%. Whereas we Indians are in between the classical Asians and the Caucasians. We fall somewhere around 30% incidence in India. You can see 24 to 30% is the incidence of EGFR mutation in India. So most commonly we find exon 19 deletion, nearly 50%, and the other 40% we find exon 21 point mutations, that is L858R. So deletion exon 19 is the most common, and the next commoner one is the L858R point mutation exon 21 region. And then for patients with advanced NSCLC harboring exon 19 or 21, TKI-based therapy are used as a rule. And other than these mutations, we need to see which mutation it is, and we have a specific targeting it. For example, if you have a exon 21, exon 20, then we need to target it with positionib. So it depends on which type of mutation, and accordingly we have afatinib or positionib being available to target that particular uncommon mutation. Then we have so these are the comprehensive trial programs in EGFR TKIs. You can see right from 2004 to 5, and then we had the IPAS study, which was for geftinib, first line in 2009, and then we had the Lux lung trials, that was for afatinib, and then we have the FLAURA right now, where you can see uh, uh, the best overall survival which we have seen with the third generation TKI in the FLAURA data. And what is so this is uh, uh, these are the curves, so this is the progression free interval curves of different TKIs. So we have the three most potent TKIs in the screen. We have afatinib versus gefitinib. You can see the 12 months is the progression free interval in Lux Lung 7, and then we come to Archer, and then you can see the separation of curves that happens in the three. So you can see the uniqueness of the flora KM curves are the early separation that we see in patients with NSCLC with these EGFR mutations. So whether you look into afatinib, whether you look into the Archer study of decomatinib, you can see the early and consistent separation of curves as far as PFS is concerned. So this is basically a cross-trial comparison, but however, whatever evidence we have, the most important thing is early and sustained separation of curves right from the early part of the disease with this the third generation TKI, that is osimertinib. So early and sustained survival benefit shown by clear separation of curves within 3 months and maintained throughout the follow-up. So you can see the other two TKIs where the responses are delayed, and you can see the separation nearly, if it's a afatinib, nearly up to after 12 months, and then if you can see the decomatinib, the separation happens after 6 months, whereas if you look into osimertinib, the separation happens as early as less than 3 months. So this is the uniqueness of the separation of curves as far as the third generation TKI, that is osimertinib, is concerned. So again here, if you look into the so this is the head-to-head studies show second and third generation EGFR TKIs provide significantly longer PFS versus first generation EGFR TKIs. So you can see here the comparison between erlotinib and gefitinib, and you can see the PFS is around 13 months for erlotinib versus gefitinib, and then we have so definitely if you look into the PFS, erlotinib has a numerically superior PFS when compared to gefitinib, and then we have the comparison of afatinib versus gefitinib. Again, you can see a numerically superior PFS with afatinib when compared to gefitinib. And then when you go to decomatinib, again in decomatinib, you can see 14.7 is the PFS when compared to gefitinib. And then we have osimertinib, which has the highest progression-free interval. So this is the data we have. Gefitinib having the least PFS, followed by erlotinib, followed by afatinib, followed by decomatinib, followed by osimertinib. So this is how the data has evolved from a first generation TKI to a second generation TKI, and then we have this third generation TKI merely having 1.5 years of progression-free interval, which is unique to osimertinib. So PFS is a direct measure of drug benefit. Immediate and sustained separation of KM curves was seen in the FLAURA study, which such an immediate and sustained response with an excellent hazard ratio of 0.46 was not seen in any one of the TKI-based studies. So the talk of the day is basically the safety. So now we have seen that there has been no head-to-head comparison between second and third generation TKI, whereas there has been a comparison between first and second generation and first and third generation. And If you look into the early and sustained separation of the PFS curves, it is with osimertinib. And then if you look into the numerically increased or highest PFS of nearly 1.5 years is seen with osimertinib. Okay. So then this is how the the difference in mechanism of action of a first, second, and third generation TKI. The first generation TKI, we have geftinib and erlotinib. Both of them are reversible EGFR binders, and you can see the efficacy is on exon 19 and exon 21 L858R, and the dose is 250 OD and 150 OD, and the bioavailability is, you can see the bioavailability is around 60% for both of them. The moment you come to afatinib, it's an irreversible inhibitor of the EGFR, the ATP binding site against the anti-EGFR. You can see the efficacy is on the exon 19, L858R, and you can see HER2 amplification and HER4. So it does act on the sites of uncommon mutation, and that's the efficacy as well. And you can see the recommended dose is 40 milligram once a day. Absolute bioavailability in humans is unknown as far as afatinib is concerned. And then we have decometinib. So decometinib is under, so it's approved now basically for first line, and then it is covalent and the irreversible binding is seen. It's similar to afatinib. It is again active against the wild type EGFR. So even an unmutated EGFR is also susceptible to second generation TKIs, especially afatinib and decometinib. That's the reason why they have increased side effects. So it's also active against the exon 19 deletion and exon 21, that is L858R, and the other two receptors. And then you can see osimertinib. This is basically the third line TKI. It's an irreversible binding, and it doesn't have any effect on the wild type EGFR. It's only effective on the sensitive regions of EGFR mutations, especially exon 19, exon 21, and T790M. And it's 80 milligram once a day, and the bioavailability is nearly 70%. So this is how osimertinib is different from the first and second generation TKIs, is that it's irreversible binding, number one. Number two, it has no effect on the wild type EGFR. It's only active on the mutated areas and not on the wild areas. So you can see this is the different structures. You can see Jeff and Erlo are reversible binding, especially to the mutated sites, and also has action on the wild type of EGFR. Whereas if you look into the afatinib and decometinib, they are pan ERBB inhibitors, and that's the reason why they have increased side effects in addition to effects. Whereas osimertinib is specific to sensitive areas of EGFR mutation. So this is an excellent slide. You can see this is the concentration of the drug that is required for the first, second, and third generation TKIs. The y-axis, the concentration increases as we go up, and these are the drugs we have. So you can see if you have a sensitive EGFR mutation, then geftinib is active at the lowest concentration, and if you increase the dose further, it starts acting on the wild type. But if you want to have a T790M activity, that you need to have a supranormal doses of IC50 as far as geftinib is concerned. Whereas if you look into afatinib, it's active both on mutated EGFR part and also on the wild type of EGFR, and that's the reason with whatever dose of 40 or 30 milligram we give, we see a lot of side effects, especially diarrhea with afatinib and decometinib. And it's also active at a higher concentration of nearly 10 times the IC50, where it's active even against T790. And this is with osimertinib, where it has taken the good parts of both the generations, where it's active at the least concentration both on EGFR mutation and also on T790M. and it hardly has any activity on the wild type EGFR at therapeutic concentration. And that's the reason why we see only the efficacy but not side effects, not major side effects with osimertinib. So, so first and second generation TKIs have high affinity to wild type EGFR, making them more toxic compared to third generation TKI, that is osimertinib. And this again, if you look into the red parts of the curve, you can see afatinib and dacometinib is lethal for diarrhea. 78, 90%, that is the incidence of diarrhea. Stomatitis, 60%, 50% with the second generation TKIs. And if you look into transaminitis, you can see allortinib having all grades of transaminitis, nearly 70%, and interstitial lung disease also are seen. And you can see the FLAURA data, you don't see any red, you can see red only with interstitial lung disease that too quite rare, with nearly 4%. So what we can understand from this is basically the amount of activity the first and second generation TKIs have on the wild type EGFR and on the unmutated EGFR. So the transaminitis diarrhea being more common in the geftinib and erlotinib, whereas if you come down to afatinib and dacometinib, there what you see is diarrhea and stomatitis nearly affecting more than 50% of patients, and diarrhea even happening in nearly 90% patients who are on afatinib. So the frequency and severity of selected clinically relevant all causality adverse events varies between the EGFR TKIs. The second generation TKIs are irreversible and they act on the wild type, and that's the reason why there is a lot of diarrhea and stomatitis as well. So in case of rash in erlotinib and geftinib, the frequency of rash appears to be higher among patients treated with erlotinib than in those with geftinib. This difference is possibly attributable to a difference in the pharmacologic properties between the two drugs. Administration of erlotinib at 150 OD thus gives rise to steady state plasma concentration through that is 3.5 times that of geftinib administered recommended dose. So basically, the proportional dose of erlotinib 150 is nearly 3.5 times more that of therapeutic doses of geftinib. So then you can see the last line. The reason for transaminitis being more frequent with geftinib compared with those with other TKIs is not known. So this is another. So we have all seen the nail changes, the skin changes, the stomatitis with these TKIs. You can see the first and second generation TKIs, where the amount of paronychia and the diarrhea are quite significant with them. Whereas if you look into FLAURA, it's so less. So diarrhea happening in nearly 81% of dacometinib and nearly 56% of study. Whereas if you look into diarrhea is around 20, here it's 35 and 30. And then you can see the stomatitis 44% versus 19%, whereas if you look into the FLAURA, it's 29% versus 20%. So there is an improved side effect spectrum with osimertinib in the form of low incidence of diarrhea, low incidence of stomatitis, low incidence of the dacometinib in at 1050 as compared to the osimertinib in the FLAURA. So the tolerable profile of either 3-4 side effects was nearly 49% in the afatinib Lux lung study, 63% in the dacometinib arm, and you can see the FLAURA, it's around 18%, which are treatment related. So significantly low toxicity profile with osimertinib. So second generation TKIs have unfavorable tolerability profile. Grade 3 and above adverse events are much higher with dacometinib and afatinib. Again, the similar data which I showed. So the grade 3-4 adverse events with decometinib were reported as 63% in patients with Archer 1050 study. This is a similar one again that led to dose reduction. Any adverse events was nearly 66%, and adverse events leading to death is nearly 10%, and that's quite significant. If you look into dose reduction is around 2%, and death is around 2% as far as osimertinib is concerned. So this is a staggering comparison between the two trials. You can see, even though we are not supposed to make strong cross-trial comparison, but if you look at the side effect profile, definitely decometinib is extremely toxic when compared to osimertinib. In 66% patients required dose reduction due to toxicity or intolerance, and nearly 10% died because of toxicity. So quite a toxic drug, decometinib, when compared to osimertinib. So then, do we have the safety of EGFR TKI, similarities and differences? As first-line treatment, second-generation TKI led to higher frequency of adverse events that are associated with pan inhibition of ERBB, such as rash, diarrhea, than the first or third-generation TKI. If adverse event severity does not lessen or cannot be managed, the dose of EGFR TKI should be reduced. Dose adjustments are more frequent in second generation TKIs. Osimertinib is considered to be well tolerated at its recommended dose. The dose management states that a 40 milligram of dose may be given under certain circumstances. So patients with osimertinib reported fewer side effects as compared to the first and second generation TKIs. Patients receiving second generation TKIs are more likely to require dose reduction. Of nearly 60 to 70% patients will require dose reduction. So depending on the adverse events, yeah. So severity, a dose modification of second generation TKI needs to be necessary to improve the tolerance. In Archer, there was nearly 66% dose reductions required. 38.3% of patients received decometinib earlier had a dose reduced to 30 milligrams, and 27.8% had required a reduction to 15 milligrams. So you can see nearly half of them require a second level dose reduction to 15 milligrams as far as decometinib is concerned. The median time to dose reduction is 2.8 months. So therefore, you can see 45 milligram per day of decometinib is quite difficult, because you can see nearly 66% of the patients require dose reduction either by first level and then to a second level of 15 milligrams. So this is the clinical trial, and these are the head-to-head comparisons of diarrhea, 11 versus 4%, and then you have the rash, and then the stomatitis and the paronychia, and you can see the PFS difference of 14 versus 16, and then you have the OS of 34, 36, and response rates also being better with osimertinib. So osimertinib is better in the way that it has more efficacy with lesser side effects, and that's why it's a third generation TKI, and it's a preferred option in non-small cell lung cancer with EGFR mutations. So dose reductions resulted in lower incidence and severity of grade 3 adverse events. However, even after dose reductions, the incidence is much higher compared to osimertinib in FLAURA data. So even if you reduce the dose of decometinib by level 1 to 30 milligram or level 2 to 15 milligram, even then the side effect profile of these pan ERBB blockers, especially decometinib, was superior. It had more side effects when compared to osimertinib. So post hoc data analysis are an issue because they conform to neither the population nor the randomization model of statistical interference. And then when we discover an apparent difference by unplanned post hoc, we may have discovered nothing but than simple coincidence. And then looking at the quality of life, Lux Lung 7 compared to afatinib showed that there were similar improvements in quality of life on both treatments. It was not superiority. And then the overall quality of life with Archer showed significant improvement from baseline in patients treated with geftinib rather than decometinib. So Gefitinib patients had an improved quality of life when compared to Comatinib, whereas in FLAURA, there was better improvement across all scores with osimertinib when compared to Gefitinib. So you can see in afatinib study, Lux Lung, there was no deterioration in quality of life, but however, there was not much improvement with afatinib. Whereas with the Archer study, on the contrary, Gefitinib arm had a better quality of life rather than the recomatinib arm. And the FLAURA is where the experimental arm, that is osimertinib, had a better quality of life. So this is the quality of life analysis. You can see the FLAURA data showing excellent improvement in quality of life when compared to the second generation TK, that is recomatinib. You can see certain parameters have in fact worsened with decomatinib, especially the GI side effects are worse with decomatinib compared to osimertinib. So global quality of life significantly worsened in decomatinib arm versus gefitinib arm. And one treatment goals in metastatic setting is to improve quality of life of patients, but with by giving drug like decomatinib, we're actually worsening the quality of life. So, so this is the study we have. So EGFR TKIs offer clinically relevant improvements, various measures of quality of life and symptoms in patients with EGFR mutated NSCLC compared with chemotherapy. You can see there is improvement in quality of life by using FACT-L scores or the EORCTQLQ questionnaire with all multiple trials, where the TKIs improve quality of life when compared to chemotherapy. So this is the quality of life measure versus chemotherapy. It did improve quality of life. So you can see decomatinib improved chest pain, increase the number of diarrhea, increased stomatitis, and significant improvement in global quality of life favoring gefitinib arm. So definitely first generation TKIs are associated with a better quality of life compared to second generation TKIs. Whereas osimertinib is unique in that it has a better efficacy and a better quality of life when compared to first or second generation TKIs. So in summary, second generation TKIs, especially afatinib and decomatinib, are burdened by toxic profile and poor tolerance. And you can see adverse events leading to dose reduction is seen in nearly 66% patients of decomatinib. Grade 3 or above adverse events is seen in nearly 63% of patients. Also, decomatinib deteriorates quality of life of patients. On the other hand, we have approved third generation osimertinib with far superior clinical profile, be it efficacy, be it tolerability, be it CNS activity, be it quality of life. So that is why the NCCN guidelines have come up with osimertinib being the preferred option for the first line treatment of EGFR mutated non-small cell lung cancer. So if you look into the takeaway points, the FLAURA trial for EGFR positive NSCLC must be taken as a reference in the era of precision medicine, showing a statistical and clinical improvement, a clinically significant improvement without any concerns due to toxicity profile and with very high activity of brain metastasis, reducing the comfortness role of whole brain palliative activity. On the other hand, second generation TKIs are burdened by the deterioration in quality of life. So you can see the comparison between osimertinib and decomatinib, 18.9 months PFS versus 14.7 months. And you can see the overall survival also, 38.9 months versus 34 months, which was not significant in the decomatinib arm. And with the deterioration in quality of life, especially the diarrhea, was more in the decomatinib arm versus the quality of life was well maintained and improved in the osimertinib arm. So with this, I would conclude. So we have three generations of TKIs, Jeff and Erlo in first, Fatinib and decomatinib in the second, and osimertinib in the third generation. So osimertinib is unique in that it is the most effective TKI when compared to first and second generation, with a PFS of nearly 1.5 years, and has the least side effect profile. The second generation TKIs have nearly 60 to 65% grade 3 toxicities requiring dose reduction. Nearly another 50% of them requires a second dose reduction to 15 milligram as far as decometinib is concerned. So that is why osimertinib is a preferred option whenever feasible in a patient with NSCLC with a identifiable target mutation. Thank you.